notification on your computer now that's letting you know it's being recorded. Thank you very much.
So good afternoon, everyone. I'm really happy to be here and to talk to you about a diagnosis of dementia. I'm a longtime neuroscience nurse who's cared for people with chronic neurological conditions, including dementia, and recognize the importance of families understanding the diagnosis. I think having that knowledge and understanding the diagnosis really gives you power and confidence in terms of talking with your healthcare providers, and also being able to anticipate the future and make plans. So I can kind of see, I don't see everyone, but if you have any questions, just feel free to unmute and ask me any questions you have. And just, you know, to let you know, also, I'm a caregiver to my mother, a long distance caregiver to my mother who has dementia. So I see this from both a professional perspective and also from a personal perspective. So we'll just talk a little bit about dementia. I often have had families say to me, I'm so relieved that my mother has dementia, or my father, and not Alzheimer's disease, but to really just have a sense that dementia itself isn't a specific disease. It's more the name for a group of symptoms that occur when the brain is affected by disease. And these symptoms are associated with a decline in memory or other thinking skills that reduce your ability to perform everyday activities. And then just to say, sometimes people think, well, as people age, they're all going to get dementia. It's just part of our normal aging. But while age is the most important risk factor for dementia, dementia isn't a normal part of aging. And people, even though it's more common, people, and we'll talk about some of the things that people can do also to reduce their risk, but people can age well into older years without dementia. Just as our muscles get a bit weaker, and as things change as we age, we may have more trouble with maybe thinking or making decisions, but that can be very different from dementia. I don't know when, oh, here I need to use this button to move slides forward. So symptoms of dementia can also vary greatly, and we're going to talk about different kinds of dementia, but at least two of the core cognitive functions must be significantly impaired, and that's memory, communication, ability to focus and pay attention, the reasoning and judgment that people have, and then some of their visual and spatial perception. So each of the conditions that we'll talk about that are the most common causes of dementia might present a little differently. For example, with Alzheimer's, people associate it more with their memory, where with frontal temporal dementia, sometimes it can be communication and language that is more disturbed initially. But again, thinking about it, just as we talk about heart disease or problems with the heart, dementia is a brain disease or a problem with the brain. I'm going to talk just first of all about MCI or mild cognitive impairment, which can be a precursor to Alzheimer's disease, but isn't necessarily. But MCI is a condition where your decline is not normal for your age and your education level, but it's not severe enough that it interferes with your daily life or your independent functioning. And so people may recognize that they're having some problems and they're concerned. And this is a really good time to having people check with their doctor and then get further referral if necessary. But other people might not notice it. So you might notice it yourself and talk to your family or your loved one. That may have been for your family member how it did start. And a large proportion, 10 to 20%, of people age 65 or older do have some mild cognitive impairment. And we know it is a risk factor for dementia, but we also know that everyone that has mild cognitive impairment doesn't lead to dementia. And there may be some actually reversible causes. And in some individuals, MCI will revert to cognition or remain stable. Someone who may be having problems may get a urinary tract infection, and just that extra fever and that stress can be associated with a cognitive decline. But then treating that urinary tract infection, you may see that that person actually has more normal cognition. But MCI is really important to recognize, important to seek medical attention, because it's really where a lot of research is focused. If we can really slow progression at this point and really prevent people from progressing to dementia, to a form of dementia, we can maybe slow the progression and the effects of the dementia. And so seeking help is really important. And a lot of the clinical trials also that are available are really focused on this stage as well. So when we talk about dementia, we're thinking about it as an umbrella term, and it's to describe this range of symptoms that are a part of cognitive impairment. But there are different causes. And it's kind of like saying we're talking about cancer, and then we're talking about the different causes or forms of cancer. Similarly, we're talking about dementia, and then we're going to talk about the most common causes of dementia. And when I talk about these conditions, and really what you're seeing here, for the most part, we're really talking about irreversible forms of dementia, because there can be a long list of reasons why people have dementia. For example, depression and dementia can really be associated together. But if we treat the depression, you may find that the cognitive impairment improves as well. But these are the most common causes for which we don't have good treatments at present. The reason when I said people sometimes talk about Alzheimer's and dementia interchangeably is because Alzheimer's is the most common cause of dementia, and it accounts for somewhere between a half and 3/4 of the causes, 50 and 75%. Following that is vascular dementia, which accounts for somewhere between 20 or 30. It's believed to be a little bit higher among our population here that are a higher percentage of Hispanic. Just like you see, vascular dementia is really meaning problems with small vessel disease in the brain. So when, uncontrolled hypertension, diabetes. So when you're seeing, driving in the street in San Antonio, if that's where you're living, and you see we have all these dialysis clinics, people having kidney disease related to small vessel disease, vascular disease of the brain is similar to that, except it's affecting the brain rather than the kidneys. And then Lewy bodies with often associated with Parkinson's disease, and we'll talk about that in a few minutes as well. And then frontal temporal dementia, which is less common and more commonly seen among people who have young onset dementia. It may be more likely to be frontal temporal. And then you can see other causes here, but we're not going to talk about them. They're less common. And then, as I said, there can be a whole list of other reasons people might be experiencing the dementia syndrome. So that's why it's important to really see a doctor when you're starting to experience these, because some things can be reversible, but the things we're talking about here really are not reversible. And then the other thing to mention here, it's rare. I don't know how rare I say that, but I don't really know. But often, commonly, people will have a mixed dementia, particularly on autopsy. When they look at the brain, there may be proteins that look like Lewy bodies. They may see all these small vessel strokes in the brain, and they may see the things in the brain that look more like the tau and the tau tangles and the plaques that look more like Alzheimer's. So often it's hard to say, and that's one of the things that's been so difficult with treatment and finding a good treatment, is that it's not one disease and then another disease, but often people will have a form of a mixed disease. So just to talk a little bit about Alzheimer's, which we talked about was the most common form of dementia. It's again a neurodegenerative disease right now affecting, in the latest facts and figures that came from the Alzheimer's Association, 6.2 million people in the US and more than 50 million people worldwide. So it really is a healthcare crisis, not only related to the numbers of people that are going to be affected, are affected now, and will be affected as our population ages. And as I mentioned, age is the strongest risk factor for Alzheimer's disease, but also in terms of the magnitude of the effect on the individual, on the family, and on the community and society. And this is just, I think, Ronald Reagan represented really what was a classic case of Alzheimer's disease, if there is a classic case. And I work with somebody from the Alzheimer's Association who says if you've seen one person with Alzheimer's disease, you've seen one person, because the symptoms will differ depending on, a lot of things, social, environmental, your own health. But Ronald Reagan, became more demented or had problems with his cognition as he aged. And really memory was a very strong feature of what his symptoms were. So it's a progressive condition, which means it does get worse over time. And again, why the MCI and early symptoms, we know that changes in the brain are probably happening as early as 20 years before we actually exhibit some of these symptoms. So it's really important, as soon as you notice something that seems like it's not normal for you or for your family member, to be starting to look at getting a diagnosis for that. And really the main, one of the most important things that happens with a diagnosis first is to rule out anything that can be treatable, and then to try to come up with what the exact diagnosis is. And when I was first starting to nurse many years ago, we really couldn't with certainty make a diagnosis of Alzheimer's disease until autopsy, when you would see the beta and the tau in the brain. But now with better imaging and with PET scans that can actually pick up those tracers, they have tracers that can pick up the beta and amyloid, and even with lumbar punctures and other, and then the very extensive comprehensive neuropsych testing, people can have a pretty good idea that it's Alzheimer's or another form of dementia. So as I mentioned, it mostly affects people over 65 years of age, and the high majority of the 6.2 million Americans that are affected. And we know that's an underestimate because many people do not have a diagnosis, but those that have a diagnosis, we know the vast majority are over 65. At 65 years and older, it affects about 1 in 9 individuals. But as people age, when you get to over 85 years of age, 1 in 3 individuals will be affected. And the symptoms can vary, but they include mental decline, difficulty thinking and understanding. People may have delusions, disorientation, forgetfulness. Memory is something that people really associate it with dementias. Difficulty concentrating, again, memory, inability to lay down new memories. And probably all of you on the talk today know that people sometimes forget what they had for breakfast, but they can tell you what happened 20 or 30 years ago. Inability with calculations, and then even recognizing things and knowing how to use them. So what people would call an apraxia. I'm not sure how to brush their teeth or to comb their hair or to name what that is. So just a quick overview of a couple slides that are from the Alzheimer's Association that talk about what might be early signs and symptoms of some form of dementia, and particularly Alzheimer's disease, and what is normal aging. So again, we talked about something that disrupts your daily life. So if you aren't able to remember the names of the people that you see, or remember appointments and things that you have, and so that it is disrupting your life, that's more indicative of something going on at the level of the brain. Whereas we age, sometimes, I don't know how many times I'm on calls with people on my team, and Jennifer can attest to this, and I am forgetting names, but I do remember them later. challenges in planning or probably solving problems. So I don't know if any of you saw that that movie Still Alice, that was about a young woman in Boston in her late 50s who developed an early onset of a dementia. And I can't remember if it was Alzheimer's or another form, but I think one of the things that her family noticed was that she wasn't able to make these recipes she'd always made before, and she was really struggling to do those. And then what may be just normal aging is that we occasionally make errors, difficulty completing familiar tasks at home, work, or leisure, and then occasionally needing help with something. And so I think I'm not going to read through all of them. I'll just let you look through them, but not maybe knowing where you are, what day it is, trouble understanding visual images and spatial relationships. So having trouble finding your way around, or again, as we talked about, how to figure out how to do some things. These, I think what's different between normal aging and early signs and symptoms is the frequency of these events, but also the magnitude. I mean, they look similar, but the ones on the left really interfere with your ability to carry out your daily activities now. And then new problems with words or in speaking. And, you know, people may call this, you know, looking at your watch, unable to remember the word watch, and so call it a time clock, or some words that they will replace because they're not sure of the exact words. And then, and I've had some people tell me that really difficulty with communication was one of the first symptoms that they noticed that something was going on with their family members. And then misplacing things and losing the ability to retrace steps. And, you know, many of us say, oh, why did I go to the kitchen? I don't remember why, and walk back. But we usually remember, but maybe not even knowing we're in the kitchen would be indicative of having problems. And then decreased or poor judgment. And again, this is also some things that people have noticed where people, I don't know why these keep switching on their own. Where people have, you know, spent an abnormal amount of money or bought things they didn't need. Or with my mother-in-law who had dementia, she had 4 coats in the closet that were exactly the same because she wasn't remembering that she had already bought them. And then withdrawal from work or social activities. And this can also be just some of the fear that people may have when they know something's going on and they don't want to be, you know, forgetting people's names, or, you know, did I already say that? Am I repeating the same sentence? And so really when they're withdrawing, I think to look at, are they just kind of tired tonight? And that might be normal, but does it seem to be something of a magnitude greater than that? And then changes in personality. And depression can be part of this as well. Okay, I guess it's time for me to move on to the next slide. It's moving on its own. So what's causing the cognitive deficits in Alzheimer's? So it really, in the end of the day, it really is death of brain cells. And as they die, the brain loses volume, and you can see that here with the brains. It usually, depending on where it starts, it may start in certain areas. People talk about the hippocampus, which is an area of the brain that has to do with memory, which is often where it might start with Alzheimer's disease, which is why we might see more memory problems. And then people also lose the network, or the wires, the telephone wires, or the connections between those cells, or the synapses to move the messages from one place to another. And so gradually, as those cells are affected and more cells, people, that's the progressive nature of the disease, and more you see the different symptoms affecting their, not only their cognition, but now their motor and their and their ability to really care for themselves. So it's believed that there's 2 proteins that are really involved in Alzheimer's disease, and people talk about mostly beta amyloid and tau. And there's been a lot of studies for years on beta amyloid, and a couple of the medications that are available are meant to address beta amyloid. And I saw there was a question that someone sent about the new medication, aducanumab, and we'll talk about that a little bit, not if people have questions, but it's really meant to decrease the beta amyloid. The question is, does decreasing it actually then improve people. But beta amyloid is really a normal protein that is really essential for normal growth. But as people age, there can be a corrupted form that accumulates in clumps outside the neurons. So when the messages are trying to get passed, and that's why sometimes you might see someone with Alzheimer's who has, these perfectly coherent moments where the message is getting through. Other times they're slowed down. And then there's also tau, which again is a protein, which is really important for stabilizing the structures in the cell. But changes in brain chemistry really cause it to come away and start clumping and sticking together. So then you get these tangles or these long filaments that disrupt the brain's ability to communicate with other cells. And again, these changes are believed to have been happening early, up to 20 years, gradually starting. And as we accumulate more beta amyloid, it can then also lead to rapid proliferation of tau. And this is just a picture from the NIH that just shows the cells. So you can see the neuron or the cell body here, and then you see all these axons, taking the messages along to different cells. And so you can see these tangles kind of in the cell getting sticky, so the message isn't able to move. And then you see these beta plaques that really prevent, again, building up between the neurons, and again blocking the messages from moving from your cells. And so you're not able to put together what you're seeing, or remember, or lay down new memories, or remember how to use a hairbrush, or remember the words that you're looking for. Any questions? I'll just take a little break here to see if people have questions about what we're talking about, or anything in the chat.
No,
I had a few.
Mabel, I think you.
Yeah, I actually wrote down a question going back to the.
Not the first person. Our commitment, I mean, you see today a whole bunch of, or you don't know, but there's a whole bunch of nursing students on today. And that's part of our mission, is to educate the next generation of healthcare professionals so that they're able to make sure that people recognize this as an important condition to be addressed. And really, people need to get a diagnosis. So why are more people getting Alzheimer's disease? We talked about the aging and people living longer now. And we talked about 1 in 9 at 65 and older, and 1 in 3 at 85 and older. So as we age, we're going to see more people with Alzheimer's disease. And you can see here the increase with each decade of life. And we talked about that already. It's also a matter of competing risks. And unfortunately, but I mean, I think things are going to change. I'm hopeful. But we don't have a cure for Alzheimer's yet, but we have lots of places working together. And I'm really, really excited. And I think it's getting close to time. It's time for sure. But I think we're going to have an Alzheimer's disease research center in South Texas. There isn't one in Texas. There's 3 in California. And so that's going to be so important for being able to really get a window into this condition and how we can support people. And that's how that happened with heart disease, stroke, and cancer, is all these consortiums that got together. And you look at the risk decreasing. This is mortality from heart disease from 1979 through to 2006. You look at stroke and you look at cancer. We see decreases in deaths from these diseases, but unfortunately that means people are living from these diseases. And I'm now hearing of people that have stroke and dementia, people that have had cancer and have survived, cancer survivors, they're older with dementia. So we need to find a way to also treat dementia and I'm hoping in the near future, I don't know how near, but having pictures that look like this for dementia as well, that were and for cognitive decline. So it's a matter of competing risk. People haven't died from these conditions, but they've lived now to be getting Alzheimer's disease. So just changing to vascular dementia, I talked about it a bit in the beginning, that really is these small vessels which in the brain get damaged and then they don't get blood flow through them. And I've worked a lot, that's actually where most of my work has been is with people with stroke and their family caregivers, and saw a lot of people that would come to clinic and say that you do an MRI scan because they'd come for a small stroke, but when you look at the MRI scan, they've had a whole bunch of other small strokes that they didn't notice because they maybe weren't in eloquent areas of the brain where, you know, they didn't lose their speech or lose their motor strength, but now they did with this. And so it's one little, if it's a little stroke deep in the brain, depending on where it is, may not affect you. But if you have a whole bunch of areas in the brain that are damaged, now you're affecting cognition. And that's what they call vascular dementia. So the location, number, and size of brain injury determines whether dementia will result and how it'll impact on an individual's thinking and also their physical function. So this can be where people have a whole bunch of little small strokes that then, with that cumulative damage, and it's often from uncontrolled hypertension and diabetes, over time can lead to cognitive impairment. So a vascular cognitive dementia. Also, if someone has a large stroke and there's a large area of the brain damaged, where you've seen people where they may have cognitive problem, or where they may have problems with their speech, they may be weak on one side of the body. Sometimes post-stroke, those people can end up with cognitive decline as well. So either from the small little strokes or a very large stroke could also lead to dementia after the stroke. Not always, but could. Dementia with Lewy bodies really, I think, has come more into the forefront with Robin Williams, who actually, that was his diagnosis. This is an amazing movie. I just saw a documentary on Robin Williams. If anybody on the call today or on the conference today is caring for someone with dementia with Lewy bodies, I would really strongly recommend you try to search for that. I think it's available where you can stream in different places on the internet. It's really brought to light, and Robin Williams' wife is doing a lot in terms of advocacy now for dementia with Lewy bodies, which can be a difficult diagnosis. Again, another form of dementia, often associated with Parkinson's disease. So people may have some of the movement disorders, but they may have the cognitive changes first. But it's associated again with abnormal deposits of a protein, in this case, alpha-synuclein in the brain. And these deposits, called Lewy bodies, now affect different areas in the brain, which again can affect areas that we think about with Parkinson's and can lead to problems with thinking, movement, behavior, and mood. There can also, people can have very severe symptoms that are associated also with their autoregulation. They can have problems with blood pressure, hypotension, where their blood pressure is very low, abnormal sweating, and then also with bowel and bladder problems. But again, there can be two diagnoses of the Lewy bodies. It can be dementia with Lewy bodies, and that's often associated with Parkinson's, but the dementia seems to be the initial presentation. Whereas also you can have people who present with Parkinson's disease and then over time may develop some cognitive impairment, Parkinson's disease dementia. So the earlier signs may differ, but it's reflecting the same pathological changes or biological changes in the brain, and over time they may look more similar. So just to give you a sense, again, what you see is memory doesn't necessarily come up as the first problem here, whereas Alzheimer's, you really think about memory. People may report hallucinations. It may be visual, sound hallucinations, smell. They also, I talked about the poor regulation of body functions, and these can be really serious. People can have very serious hypotension, so low blood pressure when they stand and just in general, and then also with problems with constipation. They also will have some cognitive problems, which may be confusion, poor attention, memory loss. And then sleep disorders often, where they really have bad dreams or maybe having problems with their sleep. And then the movement disorders, which are also associated with Parkinson's, where they have a slow movement. They may have a tremor or have problems initiating movement. So you can see it looks a little bit different than where really with Alzheimer's, we saw the memory and the cognition first. Over time, again, as more parts of the brain are damaged by the pathological processes, they may look more similar, but the movement disorder is an important feature here. And then also the hallucinations can be more consistent with Lewy bodies. And then just to talk about the last type, the frontal temporal dementia. And as I mentioned, in people under 60, it tends to be the most common cause of dementia, although it can affect older adults as well. And it affects as many people as Alzheimer's disease in that younger age group. So when we see someone with early onset, most commonly it's a frontal temporal dementia or an Alzheimer's, one of those two. And just as the name suggests, it really is affecting the frontal and the temporal lobes of the brain. So really can have profound impact on language and also with behaviors, and then also with motor, with your ability to with your muscle involvement. People talk about, just trying to give you examples of famous people that we've heard about, with Reagan, with Alzheimer's, Robin Williams with Lewy bodies. People think of that Ravel, the composer, when he was writing Bolero, and if you've listened to that, you know how it kind of seems to be, all this stuff coming together in his brain. There's suggestions that he probably was writing that when he had, or composing that music when he had frontal temporal dementia. And this is also a painting by someone with frontal temporal dementia. It's actually very beautiful, very artistic, but kind of probably expressing all these things that are going on in the brain with the behavioral that's happening in the frontal lobe, and the inability to express themselves with their temporal lobe. Often some of the very first signs are really behavioral problems, difficulty with decision making, people not being able to make good decisions at work. We had a conference a few months ago where we had a family caregiver speak on it, whose husband had a diagnosis of frontal temporal dementia at a very early age, early 30s, but it took him 8 doctors to go through, and a lot of time and energy on the part of the caregiver to get that diagnosis. But it was really the behaviors that people were seeing. And we often don't expect that. It's not as common. And it can also end up in a very bad situation in terms of people not recognizing the problem with their family member they're caring for. They have behaviors. They may lose their job because they've lost some of their ability to inhibit. They've lost their inhibitions. They can be impulsive. They may be rude, and this is not them, it's what's going on in their brain. And then they have language problems. And so that it can be a very challenging disease and very hard for families. I mean, they all are, but particularly because of the young onset, which means people may also under 60 be caring for children in their home as well. So just again, the 3 main things I talked about: the changes in behavior, the impulsivity, lack of social conventions, apathy, loss of sympathy or empathy, and always remembering this is not the person, this is a brain disease. And again, it's the frontal temporal lobes. Our temporal lobes have a lot to do with our language, so losing their language, and then also our frontal temporal lobes, particularly our frontal lobes with our movements. So general weakening of their muscles or slowing of their movements, feeling incoordinated and having problems with really with movement. So that's kind of a very quick overview of what are the 3 main causes. Is there any questions? I'll stop here again. Care pays for it, but when you come to us, did you come to the Biggs Institute? just to talk a little bit about the genetics of Alzheimer's, and we do know there's different genetic components, and we'll just talk a little bit about the ApoE4 gene, which is a risk factor for dementia. It doesn't mean if you have it that you're going to have dementia. But it is a risk factor, and it tends to be more present in people that are older. It's more associated with a late onset. With an early onset, it's often more a deterministic gene. And again, talking about that same conference that we held a few months ago, we had another family caregiver on who's has had 75% of her family have early onset some form of dementia, and she also has that same gene. Each person has a 50-50 chance of getting the gene, but if you get the gene, you know you're going to have it, but that's much less common. The ApoE4 is more common, but it doesn't mean you'll get it. It's a risk factor. So just to kind of make that distinction, and if we look at we get one allele of each from our family or from our parents when we're born, and so we get we can get, there's three, there's there's E2, E3, E4, and so we can have a combination of things. E4, if you have both alleles, if you get them both, they do increase your risk, but it's fairly rare in the population. So it's a small percentage that have both, but it does increase your risk. And I always wonder, I haven't ever been tested, and I think people can get tested. My mother has dementia, her family, people in her did, but plus also my father's brother had dementia. So I often wonder, do I have these two alleles of this gene? But what we do know, which I think is really encouraging, is there's a number of studies going on looking at lifestyle prevention, more for people with either the MCI or who have risk factors for dementia. And even if people had both alleles of this ApoE4 gene that increases your risk, when they did these, lifestyle activities, socialization, mentally challenging work, they actually had a decreased risk of developing dementia in later life. So I think that's really important. And that takes me to this next slide, which is a little hard to see, but I think it's a really important slide. It was done by a commission in the UK, but it's an international team who looked at hundreds and hundreds of articles to look at really developing a life course risk, because as I talked about, probably things are happening in the brain 20 years before, up to 20 years before we develop symptoms. So they did this life course view where they looked at all of these studies and looked at associations. And what they found out is there are maybe 40% of the risk is potentially modifiable for developing dementia, and it's not specific to any type of dementia. So I don't know, they didn't specify this. They just talked about sort of the syndrome of dementia as people age. And so they found that, and they also didn't specify how much education, but less education in early life is a risk factor. And then in midlife, things like traumatic brain injury, and we've heard about that with all the press about football players, and actually I'm just watching the Tour de France right now, and they were doing these quick cognitive tests for concussion with somebody who fell, and so looking almost at all sports of bangs to the head and what repeated bangs to the head does, and so we see that's a risk factor for dementia. Increased alcohol per week is a small risk, 1%. So and then hypertension, obesity in midlife, smoking, physical inactivity, diabetes, these kind of things that we've been talking about in later life. So a lot of the medical factors that we've talked about, blood pressure, diabetes, and there's getting to be very good evidence about blood pressure and cognition. Reducing blood pressure in midlife is really associated with a lower risk of dementia in later life. So if you or your family members have problems with hypertension, make sure it's treated. And really, it seems to be still, we don't know how low, but certainly being at 120, the top number systolic, is really found to be associated with less risk. Hearing loss is interesting, and I think it's something that at a societal level, a community level, it's really, to me, a public health level that can be so prevented. They don't know why for sure that hearing loss is associated with dementia. Is it a marker of something going on in the brain? Or is it related to the social isolation? But there have been studies that show that if you treat the hearing loss with a hearing aid, people are less likely to develop dementia. So none of these cause dementia. They're all risk factors that have been found in epidemiological studies to be associated. But I talk about hearing loss because almost half of people over 70 have hearing loss, and very few people wear hearing aids. So we could correct that. But you know, and it's like glasses, where there was a stigma with glasses, and there's still a stigma with hearing aids. Plus, they're expensive. So I think if there's something we could do actually to be preventing dementia, I think hearing loss, you look at it has a big number because there's a lot of people with it. And then I want to talk about two other things: social isolation and depression. And we know how important social isolation is now. We know there's so many studies that show it associated with mortality. It has some of the same risk factors or some of the risk as smoking and hypertension and other things. So the importance of doing what you're doing today, engaging with other people, being part of a group, still staying engaged, and then which can be associated with depression as well. So I think this has been very, very important to getting a better understanding of dementia, to look at these risk factors that happen across the life. And we still have 60% of risk that is unknown. And I've worked with many families over the last few years. Somebody that had none of the ApoE4 genes, you know, was a ran marathons, blood pressure good, still got dementia, you know, falling probably into this because these other things were cared for. So just what can we do? So we can minimize diabetes, you know, treat hypertension, prevent head injury, stop smoking, reduce air pollution, reduce midlife obesity. And these things really are thought to reduce some of the damage, but we can also do things like education. I've just been hearing on NPR this week about older adults who are learning a new language, and you think how good that is for the brain. Ginny Funk from the Alzheimer's Association said, sometimes just try eating with your other hand, challenging your brain. So doing something, and when you're thinking about something you're doing or with your family member as prevention, doing something that you enjoy that challenges you. If you're always really, really good at crossword puzzles, they're not going to challenge you. So you want to challenge your brain. So these things really are thought to increase your cognitive reserve. And, you know, interestingly, there's been people that they've done autopsies on their brain at 90 years old. They have a lot of beta and tau and other abnormal things going on in their brain, maybe in, you know, suggestions of vascular dementia as well. They were cognitively intact. And so their cognitive reserve was maintained. So thinking about these more on a societal level. And then what we do know is brain health and heart health go hand in hand. And these are some of the things we've been talking about: diet, weight, exercise. We know physical activity is really important too. And it doesn't mean getting out and running a marathon, but even just walking every day for 20 minutes, stopping smoking, keeping blood pressure well controlled, and lowering cholesterol and then glucose. So to think about what's good for your heart. And that's sometimes what gets me, again, because I have this family history that is concerning to me. I get home and I don't feel like doing something that gets me out on my bike or walking or doing something, to know that. This is the Alzheimer's Association disease facts and figures that they put out every year. This year, they talked a lot about some of the inequities in terms of Hispanics, Native Americans, Asians, and African Americans, and you can see some of the numbers there. But this is something you can find on the internet that really talks about some of the latest information, talks about the costs of Alzheimer's disease in 2021 cost in healthcare costs 355 billion, and by 2020 will be up to 1.1 trillion, and then talks about the over 11 million family caregivers who provide over 257 billion worth of really what it is unpaid free healthcare for family members. So they really are the backbone of our long-term care system. And you know, you guys are all on here today and you're representing who those people are. This is from last year. I couldn't find the 2021, but really only to highlight that we talked about as people age. So as Texans age, and we often are a retirement state, the numbers are also going to increase, going from about 400,000 people with dementia in our state. They say Alzheimer's disease. I think, again, this is an underestimate because they're maybe counting some of those others, but going almost in a few short years to 500,000 in our state. So just to go a little bit into the diagnosis, there's no single test, and we talked about it. You know what your family member has gone through, the number of tests, but and really I think it does begin with your family physician, but we talked about some of the reasons that it might be difficult. And so to be the advocate for your family member, asking for a referral to a neurologist or a geriatric physician, but it requires a thorough medical history, a physical and neurological exam, cognitive testing, and then often other tests, again, ruling out, is it a brain tumor that maybe is slow growing, could be removed, and it might prevent the cases. Sometimes, does somebody have thyroid problems? That can also is a reversible cause of cognitive decline, or vitamin B12 deficiency. So these kinds of tests are done to really say, what can we do to rule this out? And then really, we talked about, sometimes it's people say, well, why get a diagnosis? What difference does it make? But an early diagnosis is really, really important. Certainly, it gives people a chance of benefiting for treatment. And I think there is more and more available treatment. There isn't a cure medically, but there's lots of things that we can do to support the family, to support that person living. It also gives you time to plan for the future. We know it's a progressive disease. Getting an early diagnosis allows that person that you're caring for to be cognitively able to participate in a discussion about, and this is an ongoing discussion about what they want for their future, what's important to their quality of life and what they want. If they don't get a diagnosis and they never know, often the caregiver is ending up making that decision at the end. And that can be very, very difficult for family caregivers in terms of even grieving from the death of a person because they weren't sure, did I do the right thing? What did that person want? I've had caregivers lessen anxieties about unknown problems. I've had caregivers say, I didn't know what was going on with my wife. I wondered, was she having an affair? She was so secretive and she seemed so suspicious and things were very strange. I was relieved when I knew it was a brain disease, when I had a name to what was going on. So just being able to name what's happening with your family member. And then certainly there's more and more drug trials going on. I'm going to skip to the Biggs, and we work very closely at UT Health with the Biggs Institute for Alzheimer's and Neurodegenerative Diseases, which is really an amazing resource for our community with the comprehensive care they provide, but also with the opportunities to participate in clinical trials and potentially find things that will be helpful and advance research. And then, as I talked about, the opportunity to make decisions in terms of living arrangements, financial arrangements, and future care. And then to develop your care team. Family caregiving can be one of the hardest roles that families take on, and doing it alone makes it even harder. So informing yourself as you're doing today about what does the diagnosis mean, what are things that can help me, but also developing your care team. You can't do this alone. So having a care team, whether it's family members, and each of you know what your resources are in terms of family support and financial resources, but being able to form that. And then also with that diagnosis, it probably provides you with access if you have somebody that's younger, because a lot of our resources are for older adults, but with the diagnosis of dementia, it can provide an earlier access to some resources. So importantly, to find a doctor you're comfortable with that can help you through this. And then you should be referred to someone who specializes in the diagnosis and treatment of Alzheimer's and related dementias, such as a neurologist, psychiatrist, or geriatrician. And then important that the family's included in the appointments. This is a disease that doesn't affect an individual, but affects the family. And certainly the primary goal of treatment is to enhance the quality of life and maximize functional performance for the family, knowing what is important to their quality of life and to you as a family. And as I talked about, family caregivers play an important role in care planning for their families with dementia, and they provide over 80% of the care required for their family members. And this picture is kind of near and dear to my heart because it's a person, Sharon, who works with us with her husband who had Alzheimer's. This is my mother with my nieces and nephews who care for her. And then another person that works with us who cared for her grandfather with Alzheimer's. So really, we understand and recognize the critical role that family members play. I'm not going to go through this because I've been talking for way too long, but just to talk about, we know it's a progressive disease, so we know that over time things will change and no single person looks the same, but as the disease progresses, it'll require more and more care with their activities of daily living. In early stages, it may be directing them a little bit or coaching them. Maybe they forget to take their medication, so it's putting them in front of them. In middle stages, you may be really needing to say, okay, take your medications now, and helping them. And in late stages, it may be crushing them and giving to them so they can swallow them. So just care increasing. And so that's important to recognize when you're thinking of your care team and what you'll need over time. There are medications that work, some for some patients or some people with dementia for some amount of time. Aricept, which really is focused more on we talked about the amyloid, so focused on that area, and different medications. There's more details about those on alzheimers.org, which I took, alz.org, which I took this from. They do have side effects to beware of those. They may slow the progression for some people for a while. They don't reverse the progression. And I think we'll talk about other treatments that can be helpful as well. Cognitive behavioral therapy for family caregivers and how to provide care also for the person. And there's more and more things, more and more, not interventions, I guess I would say treatments, interventions aimed at supporting people living with dementia in early stages. And you may have noticed when the slides flip by, we have, and she's on today, Ashley Glassner, who is a PhD nursing student that's working with us, who's doing a study talking about stigma, depression, really talking with people in early stages, because often that's a stage where you go to the doctor, they say, here's 2 pills, there's nothing we can do, see you in 6 months. And Ashley is really looking at what can we do for people with dementia in early stages. So if you have someone that you think would be able to speak with her, I think, Jennifer, we can make sure we show that slide again. Jennifer's leading Dementia Friendly San Antonio, which is really a worldwide movement to say, just like we were really dealing with people with physical disability in the 80s and 90s, grassroots advocating for them. You saw the huge number of people that are affected with dementia. And then on top of that, people with mild cognitive impairment. How can we make our communities more dementia friendly, meaning that we are an inclusive community, that where we deal with stigma, where people are valued. As one person living with dementia told me, cognition and memory are not, or intelligence and memory are not in the same bucket. I may not be able to remember things, but I'm still intelligent. So how do we create communities that understand that and don't discriminate against people? And then we have a number of community activities, memory cafes, which are meant to be an inclusive sort of social event. We have a choir, meeting with the Alzheimer's Association. Ashley also leads an early stage support group for people with dementia. And there's also one for caregivers at the Alzheimer's Association. So really, getting involved in your community. One thing that's really important, it's hard for families, I think, but I've had many people have said to me, don't hide the diagnosis, share it with people, because if you don't, you're not going to get support. And people, people may find it hard to know what to say, but the more we can talk about it, it's like cancer 30 years ago, which was a hidden diagnosis, and people would say like the big C and then not talk about it. Now we talk about it. They didn't even tell, sometimes they would tell if the wife had cancer, sometimes they wouldn't even tell her, they just tell the husband. People started talking about it. They started raising funds. They started having cures for cancer. That's the movement that I see that gives me hope for dementia. People sharing it, not hiding it behind the doors. And then finally, what can we do to enroll in clinical trials? And as I said, there's a lot of research going on the bigs now, especially as we get a center for dementia care research, talking about funding, and funding has happily increased substantially. It's still not at the level it needs to be to really help us find a cure. And then caring for yourself as a caregiver, and also making sure that people in your family, people close to you, know about these risk factors, that life course, and thinking about that. And then being socially engaged, and keeping the person you're caring for socially engaged as much as they can. And then just quickly talking about some of the resources that are available, the Glenn Biggs, UT Geriatrics, Caring for the Caregiver. The VA has a very good program, University Health System, the Alzheimer's Association, and Grace Place, I think, is opening their adult day programs in the future. They had closed them during the pandemic. MN Learn training videos you can get. And I think Jennifer is going to send you the slides so you can click on some of these. The WellMed Charitable Foundation has a program called Caregiver SOS, and they offer programs for caregivers as well. And then Jennifer talked earlier about the Area Agency on Aging. So I've really enjoyed being able to talk to you. I'm going to just, I do want to just talk about this because I think it's a question for a moment. I saw is about the aducanumab. Oh, it's a hard thing to say. Let me open the screen. Aducanumab, the new drug that has been recently approved, and there's been a lot of controversy about it, but this is on the set at the Biggs website. And Jennifer, are you seeing my slide there?
Yes, we can see it.
Yeah, aducanumab. Okay, so now I can say it. But what they talk about is who may qualify for it, and so if you have questions about it, I think talking to your physician about it, to really know, because there has been, as I said, a lot of controversy about it. But I think the Biggs, our approach toward this new drug is proactive and thoughtful, as there are some concerns about its usefulness, but we will carefully review the risks and benefits for each patient based on the latest science and careful judgment, and really who may benefit from it, people with early stage. And as I talked about with the Aricept, aducanumab is similar in that it's really looking at reducing the amyloid plaques in the brain, and then so really looking at people who do have those from a scan or from a PET scan, and then those who are at low risk of other side effects from the drug, which could be brain swelling or small bleeding. So I just wanted to talk about that. I don't know, do people have any questions about it?